Welcome to SDSF Live. Please let us know where you're logging on from. I'm Nicole Shen from Houston, Texas. SDSF Live is brought to you from the Shwachman Diamond Syndrome Foundation, providing support to families around the world. We are currently live from Facebook and YouTube. You may comment from both platforms and we'll see it on our feed. This show is public. Please do not ask or share personal information that you're not comfortable sharing. These shows serve as a library of topics on YouTube for families to access later, where it can be also translated into other languages. Our guest this evening is Dr. Blanche Alter from the NIH. She's a legend to us in the SDS world. This is the second show in our camp series. This is an encore of a show we had with Dr. Alter a couple years ago. We do have a lot of new families, so we wanted to give those new families an opportunity to ask Dr. Alter questions live. So this camp series is going to be walking our viewers through the basics of SDS. Our last show was with the SDS registry, focused on overall aspects of SDS. This evening, we're going to focus on hematology. And please welcome Dr. Alter. Hi, Dr. Alter. How are you?
Can you hear me now?
I can hear you. I can hear you.
Shall I start?
Yes, let's start with your presentation.
So the topic title is Hematology 101, and I've used the 101 to indicate that this is not really a beginner course, which would be Hematology 1, but at least in the American universities, a 101 indicates a slightly advanced course. These slides are dated, I see, from 2 years ago, and those who've heard the talk before, this will be a refresher. And for those for whom it is new, the date is incorrect. It's this year, 2022. So I'm going to begin now. The first thing we learned in medical school is when you hear hoofbeats, think of horses or zebras, or what I have added, unicorns, even rarer than zebras. And I show an example here that from a trip, the last trip I did to Africa, which is a couple or 3 years ago, where the guide was really puzzled by the dark-colored deer, and they're melanotic or black. And I had to explain to him about recessive inheritance. So what is the explanation for the melanotic animal? Well, it is due to autosomal recessive inheritance. So there's a 1 in 4 chance, which means that the melanotic animal has 2 genes for color compared with the carriers who might have 1 or none. Not uncommon in the world we know is also that melanosis can occur in other animals, and this is a melanotic squirrel, a black squirrel. Recessive inheritance depends on carriers who have 1 affected gene and 1 normal gene. And people with SDS have unaffected parents because they have 1 SDS gene but 1 normal gene. The affected individuals gets an SDS gene from each parent and therefore has the disorder as a recessive. And the children of someone with SDS would have 1 SDS gene that they would inherit from their parent and 1 normal gene. So returning to blood, there are only 3 kinds of blood cells that you need to know: the red, white, and blue. Red cells, white cells, and platelets. And back in the dark ages, or a number of years ago, before even I started my training, the way to determine whether somebody was anemic is to put their blood into these special tubes, which were developed by Max Wintrobe, and so they're called Wintrobe tubes, and then they would be centrifuged. And these are a variety of examples of the red cells at the bottom, plasma at the top, white cells layered on top in leukemia, increased in number. This is someone with a very high red count. This is someone with anemia, because the red cells which spun down are very low. In hematology, many of us trained in a manner in which we would get to look at the blood cells under the microscope. So the red blood cells are here. With the stain that is used, they actually turn orange or reddish. Platelets are the little pieces here that help blood to clot, and white blood cells of various varieties are shown here, with bluish for the cytoplasm and purplish for the nucleus, which has the DNA. In aplastic anemia, which could occur also in Shwachman Diamond Syndrome with a low blood count, the blood cells would be quite sparse. The role of the red cells is to carry hemoglobin, which is a red pigment. They carry oxygen from the lung to other tissues that need it, and the lifespan of a red blood cell is around 4 months. So red cells that are newly released from the marrow contain material that can be stained for DNA, which is nuclear pieces, and that is what makes protein. The reddish throughout the cell is the protein hemoglobin. Fetal hemoglobin, which is a topic that I've been studying for a number of years, there's a special stain described by Drs. Kleiauer and Betke, and the cells that contain fetal hemoglobin actually stain bright pink, or less pink if they have a mixture of fetal and adult hemoglobin. Platelets have the role of helping blood to clot. They lived for 7 to 10 days, and low numbers lead to bruising, petechiae, nosebleeds, internal bleeding. There are a variety of kinds of white cells, also called leukocytes. Many are phagocytes, or eaters, phago meaning eat, neutrophils, which last a matter of hours, monocytes, days, eosinophils and basophils, which are different kinds of white cells, can live for hours, and lymphocytes can be very long-lived and live between months and years. The function of white blood cells is shown here. Neutrophils are the phagocytes, as I said, so they'll eat bacteria and fungus. Lymphocytes are kind of regulators of other cell types and also make antibodies. Monocytes eat particles coated with antibody. Eosinophils are increased in allergies and fight parasites. Basophils can also be increased in allergies. So phagocytes are shown here. They're also called polymorphonuclear or segmented or granulocytes. The segmented refers to, and the PMN refers to the nucleus, and the dots are the proteins provided to counter bacteria. Early forms are called bands or juveniles. They can be determined by the shape of the nucleus. The first line of defense against a bacterial infection is intact skin and lining of the mouth, throat, and intestines. The second line is shown here, the neutrophils, which eat bacteria and kill them, and low neutrophil number will increase susceptibility to bacterial and fungal infections. This is taken from the American Society of Hematology that has an image bank, and it's their view of Shwachman Diamond Syndrome or neutropenia. Basically, it's almost a three-dimensional picture with little granules of all the enzymes within the cells. Lymphocytes regulate other white cells, make antibodies, and proteins that act as flags to stick to bacteria and viruses, and lymphocytes will tell the other cells what to eat. Monocytes are phagocytes. In other words, they like to eat. They can become tissue macrophages, and the cells in the tissues or in the circulation will eat particles tagged with antibodies. So here is a bacteria coated with an antibody, and that would be eaten by these cells. As most of you are aware now, blood is drawn into tubes and then sent to a machine. This is one of many different kinds. And the result, the printout is a complete blood count, or CBC. This is a really old one from 1985, because most of what is produced now comes out in the computer. This one, in the old days, that actually would be printed out, and you could be handed a slip with the white count, the red count, hemoglobin, hematocrit, mean cell volume or size of red cells, mean cell hemoglobin, etc. And the platelet count was included as well. So red cells normally are measured by the hemoglobin, abbreviated HB or HGB, depending on whether you're US or British based. The normal is about 12 to 15 grams per 100 mils or grams per deciliter. It may be lower in normal children. Hematocrit is obtained by spinning the blood and looking at the percent of the spun cells that are the red cells, as I showed. The normal is 35 to 45%. And anemia is sometimes expressed as low H&H or low hemoglobin and hematocrit. It's not really a ratio, even though it looks like one. It's just hemoglobin, should probably say comma hematocrit, not this slash. Platelets, normal platelet count is above 150,000 up to about 400,000 per microliter. And thrombocytopenia is a term for low platelets or thrombocytes. White cells, leukocytes, the normal is between 5 and 10,000 per microliter. The differential of white cells usually shows you the percent of neutrophils, bands, which are immature neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Leukopenia, hard to say, means low white blood count. Absolute neutrophil count, which may be abbreviated as ANC, is the total white count times the percent of neutrophils. So if there's a white count of 5,000, 30% neutrophils, the ANC is 5,000 times 0.3, or 1,500 per microliter. Normal is above 1,500, so anything above 500 is really okay. Low is 200 to 500, and very low is below 200. So neutropenia is low neutrophils. So a CBC, in summary, is a quick and easy assessment of numbers of blood cells. It's relatively inexpensive. It's a single test that tells us more than we ever needed to know about a blood disorder, measures all 3 cell types, red, white, and platelets, and provides lots of other valuable details that the physician will look at. Now, what are the causes of anemia? Decreased production, and that can be detected by seeing a decrease in the reticulocyte count, because reticulocytes are the newly synthesized red blood cells. It can also be due to increased destruction, which is hemolysis, and in this case, there will be an increase in the reticulocytes as a compensation. Blood loss may also have increased reticulocytes, but it takes, sometimes blood loss is obvious, but otherwise the physician may have to distinguish between decreased production and increased destruction of red blood cells. Aplastic anemia, abbreviated AA, is pancytopenia, or all cell types low due to decreased production, and may be associated with a bone marrow that is hypocellular, that has fewer cells than one would expect. Leukemia is a malignant proliferation of immature cells, so there are too many cells. Myelodysplastic syndrome is low cell cytopenia with a sometimes hypercellular bone marrow, ineffective production. A bone marrow test, which many of you have had or have seen, involves a needle to aspirate the marrow, or longer needles to take a biopsy, which is an intact piece. And this is a really old slide, which is too thick, but it shows that the aspirate in the needle is put on the slide and then smeared out to look at under the microscope. These are slides that show how preparations can be made. These are not yet stained. The bone marrow biopsy, this is normal. I was taught that the blank spaces, which are fat that has been eluted away during the staining process, would reflect about the age of the patient. In that case, since we've got about 10 to 15% space, this would be a normal in a teenager. This is an aplastic where the white spaces between the cells are greatly enlarged because there aren't any cells or not enough to fill the spaces. A normal aspirate is shown here. These are the red cells or erythroid precursors. They contain nuclei, and as the cells mature, they get smaller and eventually down to the size of a red blood cell. And the nucleus becomes very much smaller until it is finally extruded and cleared out by the spleen. Myeloid or white blood cells are shown here with the same stain. You can see the red cells are the orange, but everything else has bluish in the cytoplasm. Some are lymphocytes and some are myeloid cells or white blood cells. This is an aspirate from a patient who had aplastic anemia. It's not a great specimen, I must admit, and it's from many years ago. But what you can see are a lot of nuclei with some cytoplasm. Maybe these are lymphocytes. This would be an erythroid or red cell precursor. This is a stain for bone marrow iron, which is often increased in a couple of conditions, one of which is iron overload from a patient who's getting a lot of transfusions. And the other, there are genetic disorders associated with iron retention. The iron stain is blue. It's even darker when there are clumps of iron. And a leukemic bone marrow shows a lot of white cells that look very similar and are very immature. And that was from ALL, and this is from acute myeloid leukemia. Again, the type of leukemia depends on what the hematopathologist sees under the microscope. So hematopoiesis is, I'm just checking, it's hard to spell and even harder to say, but it's the study of the formation and development of blood cells. It takes place in the bone marrow, and it involves stem cells. This is what we call the hematopoetic tree, where you start with a pluripotent stem cell, which, as it matures, makes a couple of decisions. One is it's going to be in the lymphoid lineage, which would be lymphocytes, either T cells, which make antibodies, or B cells, which make gamma globulins, and the hematopoiesis that is not lymphoid, which makes white cells, red cells, and platelets. And this is something that is easier to study offline than to show online. Except, of course, the eosinophils are eosinophilic. They're sort of orange. But the other cells are the pink and blue. And then this is a non-colored version where it's easier to read the type of cells. This is a pluripotent stem cell, the multipotent stem cell, the colony-forming units that form red cells, platelets, and a variety of white cells, or the lymphocyte lineage, which goes off on the other tangent, if you will. We sometimes use the term dysplastic marrow, which means that the cells look unusual. Erythroid cells in myelodysplastic syndrome may be large, megaloblastic, multinucleated, have nuclear fragments, increased immature forms, or even have rings of iron around the nucleus called ring sideroblasts, or sidero for iron. The myeloid marrow will have immature forms and either under granulation or increased granulation. And the megakaryocytes, which are the precursor cells for the platelets, in the marrow, they are large cells with nuclei, and they be too many or too few lobes to the nucleus, small forms, or increased nuclear cytoplasmic ratio. The erythroid marrow in myelodysplastic syndrome may be unusual and have cells that are binucleate, excuse me, or multinucleated. Overall, then, the white cells may be a little abnormal in terms of how many lobes they have, and the platelets or precursors or megakaryocyte precursors are multinucleated. So hematopoiesis is the term for blood production. Starts with self-renewing cells, which divide and eventually differentiate. And as they terminally differentiate, they are extruded from the marrow into the circulation. A little about the genes for Shwachman Diamond Syndrome, although I gather this has already been clarified for you. Most of the cases in the medical literature are classical Shwachman Diamond Syndrome with mutations in both of the SBDS genes. There are a few other genes that may be involved with patients who clinically appear to be like the Shwachman Diamond patients. And that's the end of my slides, and I'm happy to take any questions. So I will rely on someone else to change the appearance.
We're all good. Thank you,
Yes.
Dr. Alter. That was fantastic. You did right on time.
Okay.
We don't have any questions, but we want to thank.
Well, why don't you read my T-shirt to them?
If
this were a camp, I would be wearing this.
I enjoy you so much, Dr. Alter. No one wants
what
advice.
It says, I'm trying to read it backwards because I'm seeing a mirror image, but it says, no one wants advice, only corroboration. And keep that in mind when you deal with your physicians, which is, you've already made up your mind about what you want to do for your child or yourself, and you need someone else to say that is correct, or maybe that isn't correct.
Yeah.
So
that's such good advice. I miss you at camp, Dr. Alter.
Well, I will tell you a story about camp, which is that this year, first of all, you should all appreciate that Camp Sunshine really does have your best interests at heart. And the fact that they're telling you not to come means they don't want people to get sick. They did introduce a mode where families who could drive there within one day without staying anywhere overnight could come and stay in the family pod. But they weren't inviting any physicians. They didn't want lectures. They didn't want psychosocial advice. They didn't want any of that. It was just to give you the camp experience. So if you're still interested, contact the camp and find out what's going on, because I have no idea.
Yeah. We miss you so much. So you retired from the NIH now, right?
In a manner of speaking.
Okay. Okay.
I'm what's called a special volunteer.
Oh, okay. Okay.
Which means that I do Zoom in on talks and give advice to families, and some patients know how to find me. But I've moved away. I'm closer to the camp, actually.
Oh,
and I was very disappointed that I couldn't just get in my car and drive there in 2 hours. And hopefully that will all change by next year.
Hopefully.
But it's really important that they keep your health under their best interest.
Definitely. We're so thankful for all the work you've done with bone marrow failure. You really are a legend in this space, and we're lucky. The SDS community is very lucky to have you. I don't see that.
I'm looking at the public chat, and I see one from Joan Mowry at the bottom saying, "We miss camp." Yes, we do.
We do.
We do.
And I miss that. I miss the doctors a lot.
Well, you're all sort of in the hands of your own doctor at home, instead of the fact that at camp there were half a dozen doctors who could give you half a dozen opinions, but also who took care of all the different specialties that are relevant to SDS. And Camp Sunshine initiated, do I have time to give you a little history?
Yeah, you have a half hour.
So
the show is yours.
Camp Sunshine is at Point Sebago, or Lake Sebago, and there was a fee for attendance camp, which is that a family could go and initially stay in a trailer and now stay in a little cottage. And the adults would go golfing and the kids would be taken care of. I'm not sure how much of that has gone on this year. All I know is that families are not going to be there, and psychosocial is not going to be there, and it's going to be just a camp experience, which is great.
Which is fine.
It's
really a beautiful experience.
You get out on the lake, and there are paddle boats and canoes and all sorts of stuff, plus activities for the kids. There's
here
something
comes
that just
here comes the questions now. Thank you for hanging on. So Joan says, do you think blood tests will ever take the place of a biopsy? Because I know they're working on that, right? They're trying to get the blood test sensitive enough.
Well, what's happened is, in the world of cancer, they've said that they could take blood and find within the blood signs of some certain cancers. I'm a classically hematologically trained hematologist, and I don't know. There certainly is there's an abnormality in the bone marrow of some patients who may be on the verge of leukemia, in which the chromosomes are not normal in number or in appearance. And there's some suggestion that just drawing blood and looking at the chromosomes might suffice instead of having to do a bone marrow aspirate and biopsy. And I know everybody uses the term bone marrow biopsy. The biopsy I showed is by taking a sharper knife, needle, and carving out a piece of marrow that is intact, and then putting it on the slide. as opposed to a bone marrow aspirate, where you suck some of the material out into a syringe, put it on a slide. The latter, you can see the cells, but you can't see the anatomy. A biopsy, you can see the anatomy. In terms of replacing a biopsy, they give you different information. And the blood test in particular might give you the type of cells, if you have the instruments that can measure that, such as flow cytometry, and you might be able to determine the chromosomes within the cells. But I think I would encourage people to not jump to new technology just because it sounds less invasive, because until the actual tests are done, comparing it head to head with what we do now, we don't know how effective it will be. And I'm trying to look at the public chat.
Greg, would you just throw up the first one from Jenna? I just want to address that real quick. About being in Australia. So Jenna says, being in Australia, the camp has an amazing reputation and fan base in the SDS community that we over here can only hope we can link up with someday. So Jenna, I just want to let you know that that's where the show came from. Was Michelle had my co-host had an idea to do one Facebook Live answering basic SDS questions, and we started brainstorming and thought we can make it a talk show and make it live and make it available, put it on YouTube and make it available to families so they could ask questions live. So that's why this show isn't on Zoom or something like that, because that really limits the amount of viewers and people that could watch it. So this show
I'm trying to think what the time is in Australia. It must be
what is
early
the time
morning.
Yeah, it says something that these families wake up at these weird times. So we try. Hopefully, this time works for a lot of people. We've had this time for a long time, but if this time does not work for our time zone, let us know. But this show
I'm trying to read Jenna Dowley's last comment.
Yeah, let's put that up. So this is a genetic question, but if you want to answer it, Dr. Alter, I'll let you. Do you see SDS-specific genetic tests beyond the SBDS gene in a standard bone marrow failure panel being available internationally anytime soon?
That's going to be a question for someone else.
Yeah. So we're going to have a genetic show hopefully soon, another genetic show. So we could table that, and I'll make sure that that's covered in that show.
Yeah, I think that, that'll depend, first of all, on what proportion of patients who seem to have Shwachman Diamond Syndrome might actually be due to the other genes. And, all of us, when we do gene tests, or at least most of us, send them to a company. Even the finest academic institutions, rather than running them themselves, will send them out. And it really depends on the panel that's available through the companies. And, if you look at the proportion of patients in an SDS registry, which I'll defer to the registry on, in which SBDS mutations, biallelic mutations, are present in the patients, that may be 85% of the cases, and I'm just guessing, I don't really know, but there are other patients who clinically look like Shwachman Diamond, but whose mutations are in the other genes. And whether the management should be identical, I think, is going to be dependent on data in registries of gathering the information and seeing how the management should be. It's just past 10 a.m. I see in Jenna Dowley's. Okay.
So this show is really for you guys that can't make it to camp. Plus, we should be interacting with these experts more than every 2 years at camp. So,
I think one of the things you might consider in the future when camp does open up is whether you can have the modality to record the speakers as they are speaking,
and then live.
Yeah, to make it live. And, we never,
We've thought about that. I don't know. We haven't had a camp since
well,
we
I don't know
started the
whether,
show, but yeah, we'd have to talk to camp about. I
and
mean,
I
the
don't
show
know
has
whether,
nothing to do with camp. I have to say that. Like,
well,
we're
that's
not
right.
an
But on the
affiliate.
other
This is
hand,
separate. Yeah.
camp is the place where you have the largest number of physicians who represent the specialties,
Mm-hmm.
mostly hematology, but some gastroenterology and others. And it might be something to consider. I mean, the camp initially didn't even have speakers. It
Yeah.
was a place for people to go and have fun. And then our group really focused on Fanconi anemia, then Diamond Blackfan, now Shwachman Diamond,
The sister.
Dyskeratosis
The sister.
congenita,
Yeah.
all others. And we've expanded that. And I don't know what their capabilities will be in the auditorium when they finally reopen
We
to
are
people.
getting, the world is getting better with these virtual conferences. I will say, Dr. Alter, that we would need to, if that was possible, uh, make sure we have enough time at the end, because it always felt very rushed for questions. Like there was a very short period of time for even the people that are in the audience. So we would need to make sure that
Well, you
we
just
have
have
enough
to
time.
space things out
Yeah,
more.
yeah.
And
That's true. That's on us above
yeah,
timing and not having
and
such rushed
it
everything.
depends what modality. And
Yeah.
as I've commented, I'm used to other modalities than the current one. Um, and I think by a couple of years from now, everybody's going to be using on-screen
Absolutely.
type
Yeah. Virtual.
modalities
Yeah.
and interactions. I mean, I've gotten to where when my relatives phone me, I say, "This is wonderful. Let's go to Zoom. I want to see what you look like."
Yeah.
And for a while, you wanted to see who hadn't gotten a haircut. Uh, but in some sense, for people who are home alone, as I was for a while, it gives you someone to interact with rather than just talking
Yeah.
to them.
You guys are
So,
getting really, the doctors are getting really, we're all thankful for telehealth is still around in some forms. And you guys are getting really good about all these virtual conferences and doing all these type of
well,
speaking.
we are, because until recently, we didn't go to meetings. It turns out there will be a Fanconi anemia meeting in a couple of weeks. And
It's
some
in
of us,
person?
well, it's going to be, yeah, it'll be a
Wow.
mixture. I mean, for those who don't want to go in person, but some of us, they said, "You're coming." So I said, "Okay, I'm coming." Although I haven't made my plane reservation yet, I may not be able to get there.
What is going on? So I think in the last show, and I know it definitely at camp, we've talked about your bone marrow failure cohort. What's going on with that?
Well, the cohort is, as such, is still run by Dr. Neelam Giri, who's
Okay.
still there, and the Shwachman Diamond component, I think, has been handed off to Lisa McReynolds, who
Okay.
is
At
in
the NIH,
collaboration. Yeah,
everything's
they're
okay.
all at the same place, the same branch at the NIH, and the same program is still going on, and it will expand, presumably. But the NCI is still up and running, and they just, I think, in the last month or so, have been allowed back into the office.
Mm-hmm. So
Um,
that's still running. That's great that that's still
but
running.
I mean, that precipitated my retiring and moving, was that I'd been sitting home for a long time.
Mm-hmm.
Well, I'm sitting elsewhere, but things are still going on, and I'm still available. And
We're thankful for you, Dr. Alter.
so, and where I am now, I'm just outside of Boston, so I'm only a couple hours, maybe three, maybe 2.5. I'm not sure. I haven't driven to Camp Sunshine in a while.
So
Any more questions?
I don't see, just a lot of comments from Jenna, thankful for the show. And she said she would wake up at 3 a.m. for an online event. Would be worthwhile waking up for. I agree.
Well, I know the
Yeah.
Australians wish they could attend, and there is a physician from there.
Peter McCullum?
No,
Oh, Peter McCullum Center, she's saying.
yeah,
Yeah.
I forget his name, but there is in conjunction with the American Society of Hematology meeting, which does occur live these days, although it's also virtual.
Yeah.
There's a neutropenia board meeting, and that's where Shwachman is usually discussed by physicians involved in neutrophil concerns.
Right.
But again, this hasn't been held, and the person from Australia, Frank somebody whose last name I've forgotten, um, was asked if he would attend this past year, and he said he would, but then he'd be required to isolate when he got home, and he couldn't
Yeah,
spare the
it's
time for
tough.
that.
Yeah,
So
it
I
is.
think everything is evolving, and
Everything's evolving. Yep.
you just
It's
need
good.
to.
There's some really good takeaways from the pandemic. It's obviously horrible, but I think there's some good takeaways of telehealth is still, for families like ours. Telehealth is still around, and these conferences are getting
So I see a lot of comments by Jenna
Dowley.
Dowley.
She's in Australia. Joan said you did a great job as always. Thank you.
But never mind that. But the point
Yeah.
is that the Australians really should get in touch with Cass Myers, because she's got an American registry.
Right, the North. We had them on the last show, the North American Registry. We had
But
Dr.
well,
S
but the
representing.
question
Yeah.
is, how can that be expanded to include Australian patients?
I think we did cover that. It would be getting samples, I believe they said. But I mean, it is kind of for, they call it the North American Registry, but we
Well,
did
it can
cover
be
internet.
renamed.
Yeah. I mean, it's not just for them, but we did cover getting, trying to get samples to them and stuff like that.
Yeah, but
Yeah, she said yes. I've asked that question.
I think your organization needs to at least stay in touch with the Camp Sunshine people to indicate that just because you couldn't come for this year and the year before and the year before that, doesn't mean you don't want to come.
Absolutely. We're in constant contact with them. We
So,
definitely do that. So I don't see any new questions. Let's see, unfortunately. Okay. Dr. Alter, you're amazing. We're going to have Dr. Grover on next to continue our camp series. He's going to be covering GI issues. So again, we're going over all the basics of SDS again. So we had the registry on as an overview. We had Dr. Alter on for hematology. We're going to have Dr. Grover on again for GI. Again, it's encore shows mainly. Like if you want to go back to our YouTube channel, we do have most of these guests on previously from 2020. Were you on, Dr. Alter? I think you came on our show. And I think you originally came on our show in 2020, maybe 2021.
Well, as you notice, I used the same slides because.
What was the date on it? 2020?
June 2020. Yeah.
Yeah. That was the last time. Yeah. So we did a basic series.
Right. And a lot of the basics haven't changed.
Right. Basics haven't changed. So, but we wanted to give new families an opportunity to ask questions.
Absolutely.
So if you guys think of a question, we'll definitely forward it to Dr. Alter and get you back an answer. So we have the GI show coming up, and we're hoping to get genetics booked soon. And then we're hopefully going to move into research updates because there's a lot of research happening. Thank you, Greg, for running behind the scenes so the show runs smoothly. Dr. Alter has worked with Greg a lot lately.
I see something here called stop sharing. Shall I do that?
Sure. Thank you, Dr. Alter, for your time.
Nice
I hope you have a great night.
Bye-bye.
Thank you. Thank you, everyone. Bye-bye.